Welcome to the deep dive. Today, we're jumping straight into the world of pharmacology.
Okay, let's unpack this. Have you ever felt like navigating health information, especially when it comes to cholesterol levels, LDL, HDL, triglycerides, feels overwhelmingly complex?
Oh, definitely. You're not alone there.
Yeah, it seems like it. And that's precisely why we're taking this deep dive today.
It's truly interesting how our bodies manage these essential fats, lipids, and, well, what happens when those levels get out of balance. Today, we're really immersing ourselves in the world of hypolipidemic drugs. These are the medications specifically designed to manage high blood lipid levels, or hyperlipidemia.
Exactly. So we've gathered a whole lot of information, really comprehensive stuff, from the basic ways these drugs work right through to the, clinical side of things, how they're actually used.
Right.
Think of this as your shortcut to understanding these meds. We're going to cut through the jargon, focus on the key takeaways, and maybe even some surprising facts along the way.
Our goal for this session is, well, pretty straightforward. Let's get a clear picture of the different types of these drugs, how they actually work their mechanisms, and, crucially, why certain drugs are picked for specific lipid problems.
Yeah.
And this is all tailored for you, the listener, so you walk away feeling more informed, maybe more confident about this topic.
So where do we start? I guess, first, what are normal lipid levels? When do things actually start to go off track? Our sources give us some key numbers. We're looking at total cholesterol, ideally below 200 milligrams per deciliter, mgdl. Then LDL, the bad one, ideally under 100 milligdl. HDL, the good cholesterol, that needs to be higher, above 40 for men, above 50 for women. And triglycerides, ideally below 150 milligdl. Now, why do these specific numbers matter so much?
That's a great question. It really highlights the delicate balance inside our bodies, especially our circulation. Lipids are vital, yes, but too much can cause real problems. Well, take high LDL, for instance. It can lead to plaque buildup in arteries. Think of LDL like delivery trucks dropping off too much cargo, cholesterol, inside the artery walls.
Okay, yeah.
That increases the risk for heart disease, stroke. High triglycerides, too, are linked with cardiovascular issues. So keeping those levels in check is, well, pretty fundamental for long-term health.
Okay, that makes sense. Now, what pushes these levels up in the first place? Our sources talk about two main types of causes, primary and secondary hyperlipidemia. Primary is often genetic, right? Like that example, familial hypercholesterolemia.
Precisely. Primary hyperlipidemia often has a genetic root cause, meaning it runs in families. Familial hypercholesterolemia is a classic example. Specific gene changes lead to really high LDL levels, often right from a young age.
And then there's secondary hyperlipidemia. That seems more tied to other things happening, other conditions, maybe even medications.
Exactly. And this connects to the bigger health picture, doesn't it? Conditions like, say, diabetes or hypothyroidism can really mess with how the body handles lipids. And also, some common medications, like certain beta blockers or diuretics, can sometimes nudge cholesterol or triglyceride levels up.
Interesting.
So you see, doctors really need to look at the whole person, their entire health situation, when they're evaluating lipid levels.
Right. It's not just one number in isolation.
Yeah.
Okay, so we know the targets, we know some causes. Let's get into the solutions, the medications themselves. Our sources lay out 6 main classes. Sounds like a lot.
That might seem like it initially.
But maybe we can think of it like a toolkit. Each tool for a slightly different job.
That's a perfect analogy.
We've got statins, fibrates, bile acid sequestrants, cholesterol absorption inhibitors, PCSK9 inhibitors, and then this sort of others category, omega-3s, nicotinic acid.
And what's really fascinating is how each class targets a different part of the lipid story. Different pathways in how our bodies manage fats.
Okay.
Understanding these different mechanisms is key to seeing why one drug might work better than another for a specific lipid issue.
All right, let's start with the big one, statins. Probably the most well-known. Our sources call them HRD-CoA reductase inhibitors. Bit of a mouthful. What's their main job?
Okay, so at their core, statins block an enzyme in the liver. This enzyme, HMG-CoA reductase, is like a master switch for making cholesterol.
Right.
By inhibiting it, statins basically tell the liver to make less cholesterol. And because the liver needs cholesterol, it starts pulling more LDL cholesterol out of the bloodstream to compensate.
Ah, I see.
The end result is lower LDL and also lower VLDL levels in your blood.
And it's not just about lowering the numbers, is it? Our sources mention these additional benefits, stabilizing plaque, anti-inflammatory effects. That sounds pretty important.
Oh, hugely important. These extra effects, sometimes called pleiotropic effects, add a lot to the cardiovascular protection statins offer.
How so?
Well, plaque stabilization means making those fatty deposits in arteries less likely to break open and cause a sudden blockage, like a heart attack. And the anti-inflammatory part helps slow down the whole artery hardening process, atherosclerosis. It's like shoring up weak spots in your pipes, basically.
Got it. Now, specific statin names come up. We see high-potency ones like rosuvastatin, atorvastatin, and then these things called prodrugs, lovastatin, simvastatin. What's the main difference there? Is it just strength?
That's a good distinction. High-potency ones, like you said, rosuvastatin and atorvastatin, generally give you a bigger drop in LDL.
Right.
Prodrugs, like lovastatin and simvastatin, are interesting. They're actually inactive when you swallow the pill. Your body, specifically the liver, has to convert them into their active form.
Ah, does that matter?
It can. It means the liver is doing an extra step. Sometimes that can be relevant if someone's taking other drugs that use the same liver pathways. Potential for interactions,
Okay, good to know. Now, side effects, always a consideration. Our source uses this HMG mnemonic for statins. Hepatotoxicity, myopathy, GI issues. Maybe we should quickly touch on those.
Absolutely. Crucial to cover. Hepatotoxicity means potential liver issues.
Yeah.
It's why doctors usually monitor liver function with blood tests for people on statins.
Okay.
Myopathy is muscle problems. This can range from just mild aches to rarely a serious condition called rhabdomyolysis that's severe muscle breakdown.
Wow. Okay.
And GI issues, upset stomach, that kind of thing can also happen. The key is awareness. Patients need to tell their doctor if they experience muscle pain or anything unusual.
Definitely. Okay, here's something specific. Our source flagged a review question. Why are statins often taken in the evening? Is there a biological reason?
Yes, there is, and it's quite neat, actually. Our body's natural cholesterol production tends to peak overnight. So by taking the statin, especially the ones that don't last as long in the body, in the evening, you hit that peak production time more effectively.
Maximizing the impact.
Exactly. Better LDL lowering. So timing can really matter for some of these drugs, aligning with our body clocks.
That makes total sense. So clinically speaking, when are statins the go-to choice?
Well, connecting this to the big picture, statins are generally the first-line therapy for lowering high LDL cholesterol. They're used broadly to reduce cardiovascular risk.
Got it. First line for LDL. Okay, next tool. Bile acid sequestrants. Sounds like they trap something in the gut. How do they work?
That's a pretty good way to picture it. They literally bind to bile acids in your small intestine.
Okay, and bile acids are made from?
Cholesterol in the liver. They're essential for digesting fats. So these drugs grab onto the bile acids, preventing them from being reabsorbed back into the body.
So the liver has to make more bile acids?
Exactly. And to do that, it needs to use up more of its cholesterol stores. The net effect is pulling more LDL cholesterol out of the blood to make those new bile acids.
Clever. Examples are cholestyramine, cholecivellum. What about side effects with these, since they work in the gut?
You guessed it. The most common issues are gastrointestinal things like constipation, bloating, maybe some abdominal discomfort.
Makes sense.
And because they bind things up in the gut, they can interfere with absorbing other medications taken around the same time. Also, importantly, our source notes they can reduce the absorption of fat-soluble vitamins A, D, E, and K.
Oh, that's a really practical point. Need to watch vitamin levels then.
Yes, definitely something to monitor.
Okay, moving on. Fibrates. The source calls them PPAR alpha agonists. Sounds very scientific. Can you simplify that?
Let's try. PPAR alpha is basically a receptor, like a docking station, inside our cells. It's a key player in how our bodies handle fats, metabolize them.
Okay, a fat regulator?
Kind of, yeah. A master regulator for fat metabolism. Fibrates work by activating this PPAR alpha receptor.
And what does activating it do?
It triggers a few things, but the main outcomes are a decrease in triglycerides and usually an increase in HDL, the good cholesterol. One way it does this is by boosting an enzyme called lipoprotein lipase, which breaks down triglycerides in the blood.
So if someone's main issue is really high triglycerides, maybe low HDL too, fibrates would be a good option. We see gemfibrozil, fenofibrate listed.
Precisely. Fibrates are often the drug of choice for hypertriglyceridemia. They're also used for what's called mixed dyslipidemia. That's when you have high triglycerides, high LDL, and low HDL all together.
Right. Any major side effects to be aware of with fibrates?
Well, similar to statins, muscle problems and myopathy can be a concern.
Yeah.
And the risk might be higher if you take fibrates with statins.
Ah, the combination needs monitoring then.
Definitely needs careful monitoring by the doctor. Other potential issues are gallstones, and again, some GI upset is possible.
Okay. Now for the newer kids on the block, maybe. PCSK9 inhibitors. Monoclonal antibody sounds very targeted. How do these work?
They're incredibly targeted. It's fascinating science. So there's a protein in our bodies called PCSK9. Its normal job is basically to reduce the number of LDL receptors on the surface of liver cells.
And those receptors are the things that grab LDL out of the blood.
Exactly. They're like docking stations pulling LDL into the liver to be removed.
Yeah.
PCSK9 essentially tells the liver to get rid of some of these docking stations.
So fewer receptors, higher LDL in the blood?
Right. Now, PCSK9 inhibitors are these highly specific antibodies. Think of them like guided missiles that find and disable the PCSK9 protein itself.
Okay.
So by knocking out PCSK9, you prevent it from reducing the LDL receptors. The result: more LDL receptors stay on the liver surface, grab more LDL from the blood, and voila, LDL levels drop significantly.
Wow, that's a completely different mechanism.
It really represented a shift. For years, the focus was mainly on stopping cholesterol production. These enhance the body's natural clearance system. Big news for patients who didn't respond well enough to older drugs.
So it's like taking the brakes off the liver's LDL removal system. We've got alirocumab, evolocumab as examples. When are these typically used? The source mentioned severe familial hypercholesterolemia.
Yes, exactly.
Yeah.
Their power makes them really valuable for those severe genetic cases where statins just aren't enough.
Right.
They're also a critical option for people who genuinely can't tolerate statins because of side effects.
Statin tolerance. Okay.
And, as the source notes, a practical point, they're given by injection under the skin. Subcutaneous injection.
Right, not a pill. Okay, nearly there. Last couple. Ezetimibe and omega-3 fatty acids. Ezetimibe is a cholesterol absorption inhibitor. So it works differently again.
Completely different. Ezetimibe works right in the small intestine. It blocks the absorption of cholesterol that comes from your food and also cholesterol that gets secreted into bile.
So less cholesterol actually gets into the bloodstream from the gut.
Correct. That leads to lower LDL. It's very often used together with a statin to get an extra LDL lowering boost.
Combination therapy. Makes sense. And then omega-3s, fish oil, right? The source says they lower triglycerides maybe by activating QPR alpha, kind of like fibrates.
Yes, that's part of the picture. Omega-3 fatty acids, especially the EPA and DHA types you find in fish oil, are quite effective at lowering triglycerides.
Yeah.
Activating PPAR alpha seems to be one way they do this, but there might be other mechanisms too.
So they're often recommended for high triglycerides.
Yes, often as an add-on therapy, especially for people with very high levels.
Okay, wow. We've covered a lot of ground, a lot of different mechanisms. Let's try to pull it together with those clinical applications. Our source had that helpful table.
Right, matching the problem to the tool.
So for high LDL, the main tools are statins, and then for tougher cases or intolerance, PCSK9 inhibitors.
Correct.
For high triglycerides, it's mainly fibrates and omega-3s. And for low HDL, the good stuff, fibrates again, and also nicotinic acid was mentioned. We didn't go deep into its mechanism, but it's in that others category.
Right. Nicotinic acid, or niacin, mainly works by reducing the liver's production of VLDL. Less VLDL means lower triglycerides and LDL, and it can give HDL a bit of a boost too.
Okay, so that table really shows it's not one size fits all, is it?
Not at all. It's about picking the right drug, or sometimes combination of drugs, based on the specific lipid pattern you're trying to fix. Understanding the why behind those choices is key.
And just to hammer home the main points, our source listed 4 key takeaways. Let's quickly revisit those. 1, statins are first line for LDL.
The foundation, yes.
2, fibrates target triglycerides and HDL.
Their main niche.
3, PCSK9 inhibitors are for those really tough LDL cases or statin intolerance.
The heavy hitters for specific situations.
And 4, watch out for muscle issues, myopathy, especially if combining statins and fibrates.
Crucial monitoring point.
Yeah, so those 4 points really summarize the core message well.
They provide a great snapshot, yeah. A concise summary of hypolipidemic therapy.
So wrapping up this deep dive, we've journeyed through these different classes of drugs, looked at how they tackle those tricky lipid levels, their potential downsides, and why doctors choose one over another.
And hopefully for you listening, this gives you a much clearer framework for understanding conversations about cholesterol management, whether it's your own health or just general knowledge.
Yeah, maybe some aha moments about why different drugs exist.
Hopefully. You've seen how diverse the strategies are: blocking production, boosting clearance, blocking absorption.
Now, if you're curious to learn even more, you could definitely dig deeper into the molecular details of how each drug class actually interacts with the cells and enzymes. The science is pretty amazing.
It really is. Which leads us to a final thought, maybe something for you to ponder. We've talked about genetics, lifestyle, and all these sophisticated medications influencing lipid levels.
Right.
So thinking about all those factors, what do you think might be the next big breakthrough in how we manage cardiovascular health? Where does the science go from here?